Hello friends, welcome to yet another session on ARDS, the definitions. This presentation will deal with various changes in the definition of ARDS. Going to the history, Ashcroft 1967 labeled this as adult respiratory distress syndrome. The American European Consensus Conference AECC 1994. In this conference, the acute was substituted for adults, bilateral lung infiltrates, and severe hypoxemia without cardiogenic pulmonary edema. The Berlitz definition in 2012, the concept of PaO to FiO2 ratio was introduced, thereby mild ARDS comprising 201 to 300 millimeters mercury, moderate ARDS 100 to 200 millimeters of mercury, and severe ARDS less than equal to 100 millimeters of mercury. AECC definition of 1994, they defined the diagnostic criteria for ARDS was that they defined based on the severity, based on the PF ratios, mild, moderate, and severe. If the PF was less than 300, it was mild. If it was between 100 to 200, it was moderate. And if it was less than 100, it was severe. Onset was acute. The chest radiograph was bilateral alveolar interstitial infiltrates. Absence of left atrial hypertension, that is pulmonary capillary blood pressure less than equal to 18 millimeters, or no clinical evidence of increased left atrial pressure. The AECC definition timing it suggested was acute onset. The limitation of it, how much acute, no definition of what was the duration of this acute onset. The ALI category was that PF ratio is less than, ALI is that acute lung injury, the PF ratio is less than 300. The limitation was that the PF ratios 200 to 300 is leading to confusion between ALI and ARDS. Oxygenation, again PF ratio is less than 300 millimeters regardless of the PEEP. So what will be the effect of PEEP and FiO2 on the PF ratios? It was difficulty in estimating FiO2 in non-intubated patients. Now chest radiograph, bilateral infiltrate seen on frontal chest radiograph. So poor inter-observer reliability of the chest radiograph interpretation. Pulmonary artery wedge pressure, PaWP is less than equal to 18 millimeters of mercury when measured, or no clinical evidence of left atrial hypertension. So high pulmonary artery wedge pressures and ARDS may coexist. Poor inter-observer reliability of the pulmonary artery wedge pressure and clinical assessments of left atrial hypertension. Risk factors, none, not formally included in the definitions. Now, this, if we compare the AECC ALI versus ARDS, both ALI and ARDS were acute in onset. Hypoxemia, PF ratio less than 300 is ALI, PF ratio less than 200 or less than equal to 200 is ARDS. Both had bilateral infiltrates which are consistent with pulmonary edema, non-cardiogenic in both. The PA pulmonary artery oxygen pressure is less than equal to 18 millimeters of mercury. So then came out the Berlin's definition in 2012. They suggested that within 1 week, now the acute duration was given to be within 1 week of a known clinical insult or new or worsening respiratory symptoms. Chest imaging, bilateral opacity is not fully explained by effusion, lobar lung collapse or nodules. Origin of edema, respiratory failure not fully explained by cardiac failure or fluid overload. Needed objective assessments. Oxygenation, again mild, moderate and severe. 200 to 300 with PEEP or CPAP of more than 5 is mild ARDS, 100 to 200 with a PEEP of more than 5 centimeters with moderate ARDS, and severe ARDS less than 100 with a PEEP of more than 5 centimeters. So you see that based on the oxygenation and the PF ratios and the inclusion of the PEEP with more than equal to 5 centimeters, they classified to mild, moderate and severe ARDS. The origin was respiratory, bilateral opacities, X-ray in the X-rays, and the timing was within 1 week. So if we compare the AECC and what were the fallacies in the AECCs and were they addressed in the Berlin's definition, so yes, AECC just suggested acute onset. The limitation of AECC was no definition of acute, which was addressed in the Berlin's definition as acute time frame specified. Now acute lung injury category, all patients with a PF ratios less than 300, were classified as acutely in AECC. So misinterpretation, what will be happening between 200 to 300, whether it is ARDS or ALI. So Berlin addressed three mutually exclusive subgroups of ARDS by severity. ALI term removed. So the Berlin removed the term ALI and he classified it that both the three groups are ARDS, mild, moderate and severe. Coming to the oxygenation, again, since the AECC didn't mention anything regarding the PEEP, which was addressed in the Berlin's definition, and they included a minimal PEEP level of more than equal to 5 centimeters. Chest radiograph, again, bilateral infiltrates were observed on the frontal X-rays. So the inter-observer variability was there. They clarified that what is there in the chest radiograph. Chest radiograph criteria was clarified. Example, the radiographs were created. Now pulmonary artery wedge pressures. Pulmonary artery wedge pressures less than equal to 18 millimeters when measured or no clinical evidence. High pulmonary artery or ARDS may coexist. So poor inter-observer availability. So the pulmonary artery wedge pressure requirement was removed. Hydrostatic edema, not primarily cause of respiratory failure. Risk factors, none were included there. In the Berlin's definition, these risk factors were included. When none identified, need to objectively rule out hydrostatic edema. So this was a definition what Berlin had evolved and what were the limitations in the AECC definitions. So now again, if we revise that, what is the Berlin's definition? Within 1 week, bilateral opacity is not fully explained by effusion, collapse or nodules. Origin not fully explained by cardiac failure or fluid overload. Need objective assessments like echocardiography to exclude cardiogenic origin of hydrostatic edema. No ALI. ALI was checked off. There was mild, moderate and severe, and the severe was PF ratio less than 100 with a PEEP of more than 5 centimeters of water. So this was the AECC and the Berlin's. Again, there was a Kigali modification of this Berlin's criteria within 1 week of a known clinical insult or a new or worsening respiratory symptoms. In place of PaO2, on all places ABGs were not available since we are in the developing countries. So they introduced the SpO2 FiO2 in place of PaO2 FiO2 ratio. So SpO2 FiO2 ratio less than 315 was the oxygenation criteria. Again, the no PEEP requirement consistent as with the AECC definition was the Kigali modification. Chest radiograph, bilateral opacities, it was same that the note not fully explained by effusion, lobar or lung collapse or nodules. Origin, respiratory failure not fully explained by cardiac failure or fluid overload. So the proposed ARDS stratification, again, if we say that predisposing within 1 week, bilateral pulmonary infiltrates, yes, in both. This is the siesta definition. Now, hypoxemia at ARDS onset with a PEEP of more than 5, at 24 hours of ARDS, AECC onset of FiO2 more than 0.5 and a PEEP of more than 10 centimeters. Need of endotracheal intubation mechanical was there, yes, in the siesta definition, whereas in Berlin, not in the mild ARDS. So now still the questions remain in our mind are, if this is a non-intubated patient, do we label this patient as ARDS? If the patient has been applied high flow nasal cannula oxygen or a high flow oxygen, do we label this patient as ARDS? If the patient is persistent to be on NIV, do you label this patient as to be ARDS? And what about the resource limited settings where again ABGs recurrently we cannot do mechanical ventilation or invasive mechanical ventilation facilities are not available? Are we labeling these patients as ARDS? So the new global definition has the answers to these questions. If we see the new global definition, the answer to this question comes out to be the criteria that apply to all the ARDS categories, as we said, that was precipitated by an acute predisposing risk factors. Now risk factors were as defined like pneumonia, non-pulmonary trauma, transfusion, aspiration shock. Timing, as we know that it is within 1 week of the estimated onset. Chest radiograph, bilateral opacities on chest radiography or CT tomography or bilateral B lines, or consolidation on ultrasound. Now this ultrasound was included to look for the signs which we could not be picked up in the chest radiograph. They classified this specific ARDS category as non-intubated ARDS, in which the oxygenation criteria will be decided by the SF ratio, that is SpO2 by FiO2 ratio. on high flow nasal oxygen with a flow of more than 30 liters, or on NIV or CPAP with at least 5 centimeter of water of end expiratory pressures. Intubated, mild, moderate, and severe, as we already know. Apart from PF ratio, the SF ratios were included. Now, modified definition for the resource limited settings are that if we are not unable to do ABG and calculate PaO2, just include the SpO2 FiO2 ratio of less than 315. If the SpO2 is less than 97, neither PEEP is required nor minimal flow rate of oxygen is required for the diagnosis in this resource limited setting. So this was the new global definition adopted, keeping in consideration the developing or the resource limited settings. Prerequisites are the ultrasound operator should be well trained in the use of ultrasound for identifying bilateral loss of adhesions, example multiple B lines or consolidation, or other ultrasound findings suggestive of non-cardiogenic pulmonary edema. Modified oxygenation criteria can be applied in settings in which arterial blood gas or HFNO, NIB or mechanical are not available. Now, blood gas and oximetry measurement should be made when the patient is comfortably at rest and at least 30 minutes after the changes in the position. For pulse oximetry, ensure an adequate waveform and oximetry placement. SF is not valid above saturation values of 97%. Pulse oximetry is not recommended for diagnosis if hemoglobin abnormality is suspected, example methemoglobinemia or carboxyhemoglobinuria. If altitude is more than 1000 meter, apply the correction factor like PaO2 or SFO2 divided by FiO2 into barometric pressure upon 760. So basically this was the estimated FiO2, ambient FiO2, example 0.21 plus 0.03 into the oxygen flow rate. For all severity categories of intubated ARDS, a minimum of 5 centimeters is required. Patient may move from one category to another throughout their disease course. So the key differences, again, we note that what was the limitations in the Berlins and how they have been addressed in the global definition. So acute onset within 1 week of known insult or new worsening resuscitation. Rationale for updating this criteria was onset may be more indolent for some insults such as COVID. So 1 week may be still a very long time. In COVID, as we have seen that the indolent course was there, the inclusion of patients with high flow nasal oxygen will capture patients with more indolent courses, and therefore the timing of criteria has not been changed. Bilateral opacities on the chest radiograph or CT not fully explained by effusion lung collapse in the Berlin definition. Now, chest and CT are not available on clinical settings. Chest radiograph and CT scans are not available. So what they have included is the ultrasound, which can be used to identify bilateral loss of lung aerations. Multiple B lines अगर आपको ultrasound में मिल रही हैं और consolidations, as long as the operator is well trained in the use of ultrasounds. 3 severity categories defined by PF ratios. Pulse oximetry measurements of SF ratio is widely used and validated as a surrogate for PF ratios. SF can be used for diagnosis and assessment of severity if SpO2 is less than equal to 97%. So if ABG is not available, you simply use the pulse oximetry criteria, that is SpO2 FiO2 ratio, to estimate the SF ratios if the SpO2 is less than 97%. Now, requirement of invasive or non-invasive mechanical ventilation, because in the definition it was suggested that P should be more than equal to 5, is required for all categories, or a CPAP of more than 5 centimeters. The updating was that HFNO increasingly being used in patients with severe hypoxemia who otherwise met ARDS criteria. Invasive, non-invasive mechanical not available in the resource limited setting. So they included non-intubated ARDS created for patients on HFNO at more than 30 liters who otherwise meet ARDS criteria. So the modified definition of ARDS for remote resource limited settings does not require PF ratios, PEEP or HFNO. Simply this is for the HFNO category or definitions for the resource limited settings. So ARDS, 68-year-old male with abdominal sepsis, septic shock, acute hypoxemic respiratory failure, mechanically ventilated, FiO2 ratio 0.5, PO2 70, PF ratios of 150. Is it ARDS? 54-year female with history of breast cancer, COVID-19 and worsening shortness of breath, past 6 days, high flow nasal oxygenation, FiO2 0.8, SpO2 91%, SF ratio of 114. So we see that SF ratio 114 on high flow of more than 30 liters. So non-intubated ARDS, according to new global definition, this will come into ARDS. Again, if we see 39-year-old female with abdominal sepsis, gram-negative bacteremia in a small under-resourced hospital without blood gases, radiograph or mechanical ventilation. They just have an ultrasound and they had put an ultrasound to look for the B lines. So there were presence of B lines. Supplemental oxygen was provided at 15 liters. SQ2 was 85. SF ratio was 142. So according to the ARDS and resource limited, new category, again this will be a ARDS. A high flow nasal cannula, short introduction about the high flow nasal. Heated humidified high flow nasal cannula, as most call it, isn't just a standard nasal. It turned up to be a very high flow rate. It takes it takes gas, is able to heat it to 37 degrees with 100% relative humidity and can deliver from 0.21 to 100% of FiO2 at rates of about 60 liters. The flow rate and FiO2 can be independently titrated based on patient's flow and FiO2 requirement. So this completes our presentation on the new global definition and what are the changes which are included in this new global definition of ARDS. Thank you.